So welcome
Thank
everyone. Good evening or good afternoon, depending on where you're calling in from. My
you.
name's Jyoti. You've probably seen all my correspondence emails leading up to this event. I work with the Zio Plus, and we're helping host this event for Shelley. And basically, I'm gonna give you a quick rundown of the agenda, then I'll introduce Shelley and we can start with the program. So in terms of the agenda, Shelley will do her presentation. There's two components to it, and then after that, we will move into the Q&A. After the Q&A is done, and for the Q&A, we're probably going to give about 10, maybe 15 minutes, depending on how time goes, crossing our fingers. And after the Q&A, we are going to have a live raffle. So if you're interested in the raffle, make sure you stay on, because as I call your name, there's going to be two winners. You just need to respond in the chat box to let me know you're actually here. And then after the raffle, I'll hang on for about 5 minutes and share some of our relevant products from Zio Plus for anybody who's interested. All right. And just a few more things. We are going to send a certificate of attendance automatically to you tomorrow afternoon, tomorrow evening. Talk's not accredited, but the certificate of attendance can often be very helpful depending on where you're submitting it. And anything else? We're going to have a follow-up email sent after this, after the talk. Tons of information for you in there. And if you have any other questions, you can always just reply right back. Reply directly to that email, and I'll be able to help you out with anything that you need. Okay, so with that, I will introduce our speaker for this evening, Shelley Morgan. So Shelley Morgan holds a postgraduate doctorate of pharmacy from the University of New York at Buffalo. After graduation, Shelley gained experience in community pharmacy and served as a clinical pharmacist before dedicating a decade to raising her 3 children. I mean, I would say you can't tell, but that's just me. Currently, Shelley is active in both community pharmacy practice in Oakville, Ontario, and as the founder and is the founder and CEO of RX Billing Genie, a technology corporation she co-founded, which she will give you an introduction to later in the talk. I'll just say that since its inception, the app has gained great recognition, including collaboration with the Canadian Pharmacists Association and a feature on the cover of Pharmacy Practice and Business magazine. Outside of her career, Shelley is passionate about giving back and has co-founded Educate Gen Next, a charity organization supporting students in Jamaica and Canada. She was awarded the Queen's 75th Jubilee Pin for her community and entrepreneurial involvement. So thank you so much, Shelley, for being the speaker for tonight, for sharing your expertise and your experience, and we're excited to hear from you.
Thank you, Jyoti. That sounds like a really great introduction to a cool lady. Just teasing. So thank you very much, guys. Thanks for coming out and spending a hot Wednesday evening with us. I'm in Oakville, but it's about 45 degrees Celsius over here. So thanks for spending your time with us. Tonight, we're going to talk about minor, quote unquote, minor ailments, best practices, UTI, yeast infections. Just a second. I have no relevant disclosures. So as you see, I've put the minor in quotation marks. As I heard from the CPHA's last conference that pharmacists' preference would be to drop the minor part, because guess what? It's not minor to our patients. And I think by calling them minor does us a disservice as a profession. And it was kind of seen in the beginning of COVID when our premier didn't think pharmacists were frontline healthcare workers. So I think we can all agree if that we're frontline healthcare workers, and our involvement in our community is well respected and well needed. The Inspire survey found that, we were doing rationing meds, ambulatory ailments, educating our patients, reviewing medications. So we are definitely an integral part of the community's and citizens' healthcare. So it's not really minor, but it technically is. So minor ailments are medical conditions that can be managed with minimal treatment, self-care, short-term, They usually don't require labs, and they don't mask underlying more significant conditions. And we make sure that they do not have any red flags, and they will require minimum follow-up. And January 1st, 2023, the government of Ontario approved 13 minor ailments for us. And then in October, the 1st, they added 6 more. So we're just getting started. I know there's other provinces out there that have been doing this for years, but Ontario is just catching up. And these are the list of the minor ailments. At 19, we will be focusing on urinary tract infections, the uncomplicated, and vulvovaginal candidiasis, which is the yeast infection.
Hey, Shelley, sorry to interrupt, but it'd be
Yes.
great if you could talk a bit louder.
Okay, sorry, guys.
That's so much better. Thank you.
So why should we all care about minor ailments? Well, the Ontario College of Family Doctors explains that right now there's over 6.5 million Canadians without a family doc. In Ontario by 2026, they're estimating doubling to about almost 4.5 million Ontarians without a physician. So, and they also did a survey that showed that 65% of docs wanted to retire in the next 5 years. So minor ailments are going to be definitely needed to be addressed in the near future. And also the ER, UTIs are one of the most common non-emergent issues seen in the emergency room. And non-urgent issues account for 1.29 million visits in 2022-2023. And as we know, the cost of an ER visit can range $250 up to $366 dollars. So we can see that minor ailments cause our system millions. So pharmacists to the rescue, let's hope. So between January 1st and December 31st in 2023, Ontario performed over 650,000 minor ailments, and 94% of pharmacies participated. And I believe OPA had released it up till this date, I think it's up to 800,000. So as you can see, we really have made a dent, but there's still more work to do. In BC, from January 1st to 2023 to March 31st, 2024, they performed 340,000 minor ailments and contraceptive services. But of course, all this takes time and opportunity. And we'll have to do that through technology and workflow. I was lucky to attend Pharmacy U and learned about the pharmacist at intake, or P first, which kind of has us see the patient first and allows the support staff to help us with those other things like data entry, compounding, and insurance adjudication, which I will mention later because we use RX Billing GD to help with those pain points. But I've also used MapFlow and MedAssist to help with the clinical side of minor ailments. So I'd love for you guys to put into the chat what other methods that you use to help weave minor ailments into your daily practice, because I would love to learn more because we're all learning here. But our goal is to at least try and get a few minor ailments per day. So that's what I'm trying to do in my practice. And I hope everybody else is trying to do that as well. So again, my most common ones that I see are UTIs and vulvovaginal candidiasis, VVC, or yeast. And overall, 35% of minor ailments seen are UTIs. So it's a very common disease state that we see. And speaking with an ER nurse in Toronto, when I showed her the list of our 19 ailments, she said, oh my goodness, 18 of those are in our fast track. So if we can think that we are doing a greater service to the public, I think we'll try and do even more and get ourselves out there even more. So with that, it increases access points for our patients. They're treated in a timely manner because almost 50% of them can't see their primary care provider within 48 hours. And we all know what it's like to try and get into a family doctor. It's very difficult sometimes. And this way, patients can avoid the ER. For example, UTIs are one of the top 5 reasons people go to the ER. So if we can maybe pull a few of those out of the queue, it'd be helpful for all Canadians. Well, first we'll talk about a little bit about urinary tract infections. So the definition: urinary tract infections infect any part of the urinary system: kidneys, ureter, bladder, urethra, and the sites where the infection occurs: the bladder, cystitis, urethra, urethritis, and kidneys, pyelonephritis. It's quite common. Almost 60% of women will have at least one UTI in their lifetime. However, it's seen in men, especially older, and they might have prostate issues. But it is higher incidence in sexually active women, 18 to 24, postmenopausal women, and the elderly. So, and usually the most common cause is E. coli, but it can also result from fungus and viruses. But typically E. coli, because the bacteria colonizes the bowel, the periurethral area, and of course, we know about wiping front to back, but that way the bacteria can ascend through the urethra into the bladder and potentially to the kidneys. So as I said, mostly E. coli, but Life Labs offers this antibiogram, which is great because it tells you what's common in your area and what the bugs are susceptible to. So there are some risk factors for UTI. With the female anatomy, we have a short urethra. There's urinary obstructions, kidney stones, or prostate, catheter use, urinary retention. Also, sexual activity, certain contraceptives, medical conditions that can disrupt the microflora, diabetes, immunosuppression, menopause, and of course, a family history of UTIs. So signs and symptoms of uncomplicated UTIs. Most commonly, dysuria, pain, or burning sensation on urination, increased frequency or urge to urinate, the feeling to need that you have to urinate immediately, blood in the urine, some abdominal pressure below the belly button in the lower abdomen, and cloudy or foul-smelling urine can also be an indicator. So there's some signs and symptoms of complicated UTIs, i.e. the red flags we need to look out for. Fever and chills, flank pain or at the back, lower back where kidneys are, nausea and vomiting, weakness, pregnancy, or having an infant less than a month old, significant blood in the urine, male, and less than 12 years of age, or if they're postmenopausal. There's a bunch more. Can anybody think? Hopefully we can add some more into the chat of other red flags for UTI. Of course, we have recurrent UTIs, 2 infections in the last 6 months, or 3 or more in the last 12 months. Immunocompromised, spinal cord injury, if they've never been diagnosed before. That goes for every minor ailment, or they've had a previous episode in the last 4 weeks. So hopefully we'll be able to, I can't see those in the chat.
Oh
though.
yeah, I can share them with you. So
yeah, that's great.
Yeah, Deepika mentioned fever. Bradley said catheter, having a catheter in place. Lisa said interstitial cystitis.
Oh, then we didn't get the other comments from the previous question of what technology or methods
Those
everybody's
didn't come.
using.
No one shared. Nobody.
Oh, nobody shared.
No one shared.
To help each other. I want to learn to see what everybody else is doing. Okay.
So another red flag or sign is having the urge to urinate. And then
Mhm.
going back to your previous question was Health Watch smart form. Someone has shared.
Okay.
Mhm.
Also, elderly, confusion, agitation, that's another common one. So changes in their mental status, that's another one.
You know what,
So,
Shelley, while we're on this topic, a question came in. Is postmenopausal a red flag um, to refer, or is it just a risk
yes,
factor for UTI?
yes, we don't do postmenopausal because there's another one, atrophy. It could be her estrogen levels, things that we can address. So, yes, I would say postmenopausal. I would definitely have them see the doctor at least the first time so that they'll know.
Okay, great. Another one is we're going a bit back now. Is Shoppers Drug Mart, Health Watch, Smart Form. So these are good.
Thank you guys. Um, so how do we do our minor assessments um, in the community? We need something that's systematic. So the purpose of the Scholar Man is to provide community pharmacists with a systematic approach to assess each problem. And it's structured patient questioning, so it kind of gets you to have your thoughts in order and to not forget something. So we want to look at symptoms, what the patient is complaining of, characteristics, how does that look, history, if they had this before, onset, how long has this been going on, where is the pain or irritation located, what makes it worse, the aggravating factors, what improves it, the remitting factors, what medications are they on, what allergies, and what type of medical condition they might be suffering from. I got the Scholar Man's. I didn't come up with it, of course. I have taken a few CEs like everybody else here, and I've seen this example recurring throughout, and I think it's pretty good as any. So now let's look at more specifically the UTI. So the symptoms we want to ask would be about, are they having the pain, frequency, urgency? Are they having the abdominal pain, any blood? The severity of the pain, the appearance of an odor, sorry, of the urine. So history, number of past infections. Is this new? Have they had it before? Have they been treated with it for it before, and how did that work? Onset, when did it start? Was it gradual? Was it sudden? And you can discern between, is it what we think it is or something else? Location, where is the pain occurring? And like I said, with the lower back, the flanks, that would be a red flag, because that would probably indicate pyelonephritis. What makes it worse? Activities, food, clothing, drinks, and what makes it better? If they tried any, maybe they've done some over-the-counter medications that have helped. And then comes the man part of the Scholar Man. So they're looking at medication review, they're taking what they've recently taken, what if they have used medications to treat a UTI in the past, what that was, any allergies, existing medical conditions, and as I mentioned before, and conditions that may predispose or complicate UTIs, like maybe they have a structural issue, anatomical issue. Oh, sorry, guys. So this is a positive assessment. UTIs are typically treated with antibiotics. The choice of antibiotics depends on the severity of the infection, their history, and local antibiotic resistance. And as our roles as antimicrobial stewards, we can look back at the antibiogram that I had mentioned earlier, because it gives a report of local bugs, what's their susceptibility, and not to prescribe something that might be highly resistant in that area. So we don't add to antimicrobial resistance. So an uncomplicated UTI most commonly would be nitrofurantoin, and it's very effective against E. coli. We also
Shelley,
have, yes,
apologies to interrupt. Rubini's asking if you could show the antibiogram again,
oh, sure.
just for a quick minute or a few seconds.
I don't know how to do this other than go back.
There you go.
Okay,
Maybe
so
she
yes,
wanted to
here,
take a screenshot, or if you could go
yeah,
through it
so here,
quickly.
so it's great because you can put in, I put in Southwestern Ontario, and I'm community because I also have it for long-term care, because the bugs are different. So yeah, here you can see this is the number of people walking through the door that were getting their urine tested. So as I said, most people are E. coli, and then it will tell you, like here, ampicillin, we wouldn't want to give that one. It's only 63% susceptibility. Whereas when you look at fosfomycin or nitrofurantoin, those are in our purview to dispense. So it's a, it's a very interesting way to use some of that data out there.
I've shared the link for the report that you had pulled this from.
Yeah, I
So
sent
in
that
case they
to you.
want to dive a bit deeper.
But yeah, so I know they have it for, I think it was Saskatchewan, BC, and Ontario. So I'm not sure the other province life labs equivalent would be. Okay, here we are. So again, so nitrofurantoin, and we mentioned the Bactrim DS. Avoid if the local resistance is greater than 20% or they've used it in the last 3 months. We have the fosfomycin, which is so convenient and effective against multiple strains. But just keep in mind, because we can see kids 12 and older, that this is for 18 and older. And also trimethoprim. There are, we always want to use the shortest duration as possible and continue until the course is finished. There are alternative agents, but they're not under our scope of practice, like Augmentin or Cipro or Levofloxacin. So, this is our typical, usual patient counseling points. Adherence, we want to stress the importance of taking the full course of antibiotics even when they feel better. The appropriate spacing, first thing in the morning, last thing at bedtime. And typical side effects with most antibiotics, the typical softened stools, GI upset, taking with food. Of course, if you're having severe diarrhea, then we would like to call us back, and we'll discuss that or refer you to your primary care. And during treatment, we want to encourage symptom management. So that would be increasing your hydration, help flush out the system, so to speak, and pain relief, over the counter ibuprofen or acetaminophen to help manage that. And of course, we mentioned the typical hygiene, wiping from front to back to avoid bacterial spread, urinating before and after sexual activities, not holding your urine, especially for young people. These young kids, they don't want to get up and do what they have to do. So, if you have somebody who's young, that might be one of the things to think of, that making sure they're avoiding properly. And of course, wearing breathable clothes, cotton underwear, those kind of things, especially in this heat and humidity. We want to reduce bacterial overgrowth. So after the patient has been given their medications, we want to talk about symptom resolutions. In here in Ontario, we have to follow up with the patient. So, I tell them they might get help with the urgency a little quicker, but they should have a significant improvement between 48 and 72 hours after starting the medication. But these things do take time, so a full resolution can take up to 7 days, but by the day 2, 3 they should be feeling a lot better. But if day 7 comes and they're still not feeling right, then it would refer them on to their primary care provider. And with that, we can also discuss with them if this is something that's happening often, if they're getting two or more for 6 months or 3 or more in 12 months, they might want to talk to their doctor about getting it investigated, because there are options. There's even prophylactic antibiotics to a low dose daily to help avoid this. And of course, if any of their symptoms become worse, then we need to refer them on. And definitely always want to talk about prevention, non-pharmacological things that any patient can do, which is good hygiene, adequate hydration, avoid irritants, all these kind of repeated, a healthy diet. The douching is in here by accident. We'll correct that for when JOT sends it out. But and UTI test strips. I've gotten a lot of patients that come with antibiotics, UTI antibiotics with refills, because the doc doesn't have time to see them every time. But I also suggest that they get UTI test strips, just so that they might feel it's a infection, it might not be. And we don't want to treat unless it's an actual infection with symptoms. So sometimes it might be good. What I suggest is, take the test just to make sure before you do your refill and start another course of antibiotics when you may not need to. So we have our friend, female patient, 39 with 3 kids. She came into the pharmacy complaining of pain below the belly button. I feel like I have to pee every 10 minutes. Half the time nothing comes out and it burns. And I usually get up to maybe 2 per year. My allergies, I'm allergic to sulfa. Combined oral contraceptives for the last 15 years, on or off. And the last UTI she had fosfomycin, and she said she got an okay response. And again, she says she gets them probably yearly. So what do we do? Let's go through our scholar mans. What does she tell us? She told us her pain. She's in pain. She's frequently urinating. She has lower abdominal pain. She feels uncomfortable. She had it about a history. She had it about a year ago and had fosfomycin with an okay response. Her onset was yesterday, and the location she has some lower abdominal pain. And what makes it worse is urinating, makes her uncomfortable. And she took some Tylenol as a remitting factor to help with the pain. Her medications, this is the typo, was contraceptives over the last 15 years and Tylenol for pain. She has a sulfa allergy and no other pertinent conditions. Oh, sorry. I just said, what would you guys consider giving to this patient? If if anybody puts anything in the chat, that'd be great.
Yeah, I'm waiting. Let's give you guys, I don't know, 20 seconds. Let's see who shares something. Okay, so Nico is saying macrobid, yeah, nitrofurantoin, macrobid 100 milligrams twice a day for 5 days.
Yeah.
Nitro, macrobid across the board, basically.
Okay.
Cipro for one person.
Unfortunately, we can't prescribe Cipro in Ontario, so I don't know about other provinces.
It's because of the black box warning, right?
Well, no, it's just not in our list of medications that we can prescribe.
Oh, for pharmacy.
But yeah,
yes.
But yes, it does have a black box.
But everybody else is on board with macrobid, 100 twice a day for 5 days.
Perfect. Well, perfect. That's what I chose. So, except for this said 7 days, typo 5 days. And to continue with the Tylenol, 325, 500, Q4, 4 to 6 PRN. And because she has, this kind of a continuous thing with her, she might want to consider proanthocyanidin, which is 36 milligrams once daily. And both the Canadian Gastro-OB-GYN and the CUA, they both recommend adding a cranberry product to the diet to help with recurrent UTIs. So then, I did that. So then, what do we do for follow-up? Well, in Ontario, we have to inform the physician. I don't think anybody's really calling, so I think most of us are probably faxing the minor ailment assessment to the physician. And then we have to follow up with the patient ourselves to complete the MA. And that's usually within about 72 hours. You want to see about symptom resolution, make sure they didn't have any side effects from the medication. And of course, everything we do, we want to document, because if you don't document, it didn't really happen. So that's, and we would of course follow up with all our preventative measures about the urination, after sexual activity, and the wiping front to back, and especially in these hot, humid times, healthy hygiene. Okay. Our next one, vulvovaginitis, sorry. So our OB-GYN in our building said, like, this is one of her pet peeves. She hates dealing with vaginitis. So anything we can take off her plate, she'll be very happy. So it is the inflammation or infection of the vulva and vagina. Common causes include vulvovaginal candidiasis, VVC, or AK yeast infection, bacterial vaginosis, BV, trichomoniasis, and atrophy. We in Ontario can only look at the self-care yeast. So what is it? Well, it's a fungal infection caused by Candida species, primarily Candida albicans. Common in women of reproductive age, and almost 75% will experience once in their lifetime. And it is an overgrowth of Candida due to an imbalance of the vaginal microbiota. And this can come from medications, hormone changes, immunosuppression. And as said, and there are risk factors, as we mentioned, uncontrolled diabetes, tight clothing, oral hygiene. So it's kind of interesting that the good vaginal bacterium, Lactobacillus vaginalis. I'm sorry if I'm butchering these things. I'm a little nervous. I'm a little tongue-tied. So that bacterium converts glycogen into lactic acid, and so it maintains a slightly acidic environment, and it also creates hydrogen peroxide, which the lactobacilli love, and the bad microflora don't, so they're well controlled. So if these things are off balance, we're left with a yeast infection. So similar to UTI, what are uncomplicated symptoms that we're going to be looking for? Intense itching, irritation of the vulva, thick, white, cottage cheese-like vaginal discharge, redness and swelling, pain during intercourse or urination. Complicated symptoms are recurrent infections greater than 3 or more per year, secondary infections due to scratching, as you can imagine, and the impact of quality of life due to discomfort and irritation, and generally feeling unwell. Those would be things I would want to refer on. So we still have to do our scholar mans, and this is what we'd be looking at: the symptoms of itching and discharge, irritation, characteristics of thick white discharge, usually odorless, history of previous infections or treatments, was the onset gradual or sudden, where is it located, vulva, vagina, aggravating factors, heat, moisture, certain clothing, remitting factors, antifungal treatments, maybe cool compress showers or things like that, medications, hormone therapies, antibiotics, allergies. You check for the patient if they have allergies to any medications, and any conditions that might lend itself to developing a yeast infection. So typical first line treatments, and a lot of these are over the counter. Well, they're over the counter already, but we have the clotrimazole, You have 1, 3, and 7 days. Meconazole, 1, 3, or 7 days. Tetraconazole, 7. Those topicals used safe in pregnancy, or we have the oral antifungal fluconazole, which is a single dose, but should be dispensed with a topical cream because that it's not going to help with that in quick itch relief, and that should be avoided in the first trimester if possible. And just keep in mind that we want to avoid anybody who has recurrent greater than 3 or more per year in general. And for minor ailments, if they've had a yeast infection in the last 2 months, I would refer to their primary care physician. And just a FYI, boric acid suppositories, there's some possible benefits for non-albicin yeast infections or recurrent yeast infections, particularly those that are resistant to conventional treatments or just unable to take them due to possible allergy. And it works, it's an antifungal, antiseptic, so it treats the recurrent infections by disrupting the infection cycle, and definitely not to be used in pregnancy. We have, and the dosing for that is 600 milligrams suppository QHS for 14 days. And if for maintenance, if they tend to get UTIs, there's also a maintenance dosing of 300 milligrams for 5 days, beginning on the first day of the menses. This is actually quite common in our building. We have a lot of OB-GYNs and they tend to use this. And one said that this was a godsend because the patient was allergic to azole. So we do see this. Again, what can we do to help prevent this? Wiping from front to back, breathable cotton underwear, avoid douches and scented products. Think especially in this type of very humid, hot weather, wearing natural fibers is much better than the synthetic spandex type things. Lifestyle modifications, you know, if you're diabetic, have good blood sugar control, alcohol use, avoid tight clothing and underwears, don't sit in a wet bathing suit all day, change quickly. So, oh, this one got the wrong one. We're at we're back to UTIs, but yeah, sorry, that was out of order. So once you decide to use an antifungal, so same with the antibiotics, we have to stress taking the full course of medication, even if symptoms improve, and the medication is taken at appropriate times. Side effects, well, the PO, you can maybe have some stomach issues, but I would suggest taking it on empty stomach. But it is 1 dose, so there's not too much you can do after it's done. Just know for next time. We want to give some symptom reliefs, which I can buy just a tube of clotrimazole over the counter. And prevention tips, again, the hygiene. Washing the vulva with mild soap and water, no need to douche because it is self-cleaning, as we all know. Changing tampons often and pads often, that might be something to kind of stress with the younger people, you know, 12, 13, 14-year-old who might be new to having her period and might not understand. I've had a father bring his daughter in because there was no mother and she had started a period. So sometimes there's not somebody at home to talk to the young people about that. So that's where we can come in and help out our community. And again, symptoms should resolve in 48 to 72 hours. And if not, or if they worsen, then we'd have to look at referring them on. So guess who's back? MM39, she's come back now. She says her vaginal area is very itchy, intercourse was painful, and she woke up this morning with thick cottage cheese looking discharge. And she says it was like what happened a year ago. As we know, again, she's allergic to sulfa. And she's on her birth control on and off the last 15 years. And her medical history is an antibiotic completed about a week and a half ago. Oh, again, Scullerman's. For her, itchy discharge, irritation, characteristics, thick white cottage cheese, like discharge, history, previous infections, yes, treatments, yes. And she had a history of a UTI a little while ago. This was a pretty sudden onset. She woke up last night and then this morning, and it's her vulva and vagina that are irritated. When she was having sexual intercourse, it was painful and uncomfortable. She said when this happened before, she had some type of antifungal treatment. She doesn't remember what. And the medications was her birth control, but she also finished the nitrofurantoin a couple weeks ago. And she sulfa and otherwise healthy. Oh, sorry, I did it again. So what would you guys give her? Do we have any answers, Jyoti?
Not yet. Just give it a few seconds.
That's okay.
Okay, fluconazole and antifungal cream. Yep, fluconazole and mycatin cream.
Great.
Clotrimazole, if I'm saying that correctly, cream. Some are saying everyone's pretty much on board with this, something similar.
Okay,
Topical
great.
canestin for symptoms.
Sorry?
Topical canestin for symptoms.
Yeah. Yeah.
Probiotic.
Yeah. Great. Okay, so yes, there we go. We would give her the 150 milligrams with the topical cream for symptoms. And you can also consider adding a probiotic for overall vaginal health, containing lactobacillus. And I did see there is some early suggestions that lactobacillus rhamnosus and Reuter, which is GR1 and RC14, may be helpful in yeast infections, but there's not enough because there's not enough lactobacillus to convert the glycogen, to get the lactic acid, to get the hydrogen peroxide. So this could be an option because everybody nowadays are looking for healthy, non-medication ways to improve their health. So again, like I mentioned, we're gonna hopefully see significant improvement in 48 to 72 hours. We have to fax our assessment over, and we're gonna have to follow up with the patient and see symptom resolution, see if there was any adverse drug reactions to the therapy we suggested. And hopefully she's back on the mend and being busy with her 3 kids. So I just wanted to kind of just have a comparative, because you'll have everybody walking through the door and we have to decide which is the one we can see. So the UTIs, the most common are distinguishing factors, the increased urination frequency, the pain, the urgency, and possibly cloudy or foul smelling urine, versus the yeast where you get itchiness, thick white discharge, irritation, redness. And bacterial vaginosis, it's more a very fishy odor where the other ones aren't so, the odor isn't so strong. But a very fishy odor with a creamy discharge, kind of yellowish green. But there's also trichomoniasis, sorry, which is a frothy, wet type of discharge, possible itching, and some atrophy, which is more painful and discomfort. But as you can imagine, they all can cause some discomfort and pain during urination. So those are something that the patient might explain to you, and you'll have to investigate further with our scholar mans to see if they qualify for a minor ailment here in Ontario. And because we want to all obviously offer an accurate, not diagnosis, assessment, sorry, so that we can avoid unnecessary antibiotic use and ensures that the patients who require a referral get it. Okay, well, thank you very much for listening and participating. It's been great. So now I'm going to talk to you a little bit about my thing. I know Jyoti had mentioned it, and it was in the flyer. So I'm one half of RX Billing Genie. So I'm one of your genies, so to speak. I'm a frustrated pharmacist who hates to bill. And it was a problem that I found, and my father, my old immigrant father, said, listen, if there's a problem for you, there's probably a problem for somebody else. So we put our minds to it and created RX Billing Genie. So I know there's somebody out there that billing drives you crazy. You can put that in the chat. You can just put a Y for yes, because I don't think anybody loves billing. But unfortunately, it's what keeps the lights on. So it is an important factor in our day-to-day lives. So what are some of the billing problems? As we know, when we're processing a prescription and we get rejections, you call because, you know, everybody's got their Post-it notes or billing binder that's sitting underneath the counter for a few years. And we end up calling an insurance company, and it takes us maybe 10, 15 minutes per prescription if we're lucky. No, we've all had stories of having it on hold for an hour. That's not unheard of. And when I asked my tech, I said, we're not a big pharmacy, our average medium-sized pharmacy, I guess. And we were spending about 10 to 15 hours a month calling insurance adjudicators just for their intervention codes. And that drove me crazy, because that is not paid time. It's not helping anybody. The patient's getting frustrated, and they're looking at us over the glass, and we're getting frustrated. And of course, if we make an error, there are audits and clawbacks. And so we thought of a thing, how can we mitigate this for our fellow pharmacy people? So our solution is RX Billing Genie. So it's extremely simple. It takes about three steps. If you can see here on the screen, it has a list of the third parties across Canada. It's a searchable database where you can put in when you get your rejection code, you just type in the rejection code, and then you can select the answer to find the solution. So basically, we have a couple of 2-minute videos on YouTube so that you can see how it navigates. But it's basically, you open the app, you select your insurance company, you search for your rejection code, and you open the intervention/solution. Even if it tells you, guess what, the patient has to reach out to their plan administrator, that saves you a phone call just alone. So what it can do for you, it just saves you time. The technicians, the assistants, the pharmacists, whoever calling, it saves you time. You get answers in seconds rather than waiting on hold, listening to that lovely music. The app also has other billing hacks, because I used to hate billing glucometers. I would tell them to come back on Monday when somebody else was here. So it gives you those kind of tidbits, links to post-secondary schools and their insurance patient assistance cards. It's just like a little partner in your pocket type thing. The pharmacists will have time to improve their patient care and perform other professional services that are more worthwhile. Our minor ailment assessments, med checks, flu shots, etc. You know, it gets the patient the medication in a timely manner, and it gives you time to build relationships, because that is the most important thing, is to build relationships for your patient. So you can download it on any device you choose. You can download it on the desktop at your filling computer, and it sets up in about a minute. And current special is still available for you guys. It's like $30 for a year. So that's literally not even a tea. Okay. If you use this twice a year, you would have definitely saved yourself time, because you imagine if you just used it, if you're paying somebody at the hourly rate and they're sitting on a phone and not doing anything beneficial for the pharmacy, it's a waste of time and money. So it's available on both app stores or our website, where you can go and you can download it on your desktop at rxbillinggenie.com. So thank you, everybody. I hope you can connect with me on LinkedIn. Would love to hear and meet all these pharmacists from across Canada. We're on all the social medias at RX Billing Genie. So whoever follows and likes and comments on our Instagram will win a complimentary, will be put in a draw to win a complimentary subscription. So once again, thank you so much. and have a lovely evening.
Thank you, Shelley. Let me just get myself sorted here. Okay, perfect. So we have a ton of questions. I think we can get through a good chunk of them. And I just wanted to tell you in the chat, there were a ton of Y's, Y pluses.
With the frustration? Of
Okay,
course.
so let's move into the Q&A. So it's a mix of some questions on our Spilling Genie, and then majority of them are on the presentation. So I'll just go through them all over the place. So first question is, how long has our Spilling Genie been on the market?
We started in the middle of COVID when there was nothing else to do. So we started in the middle of COVID. So we've been on the market for a couple of years now.
Okay. So next question regarding UTI, I think they just wanted some clarification. Is it, if the patient is having their first UTI, is that when they require referral?
Yes.
Okay.
Yeah, because we have to, you have to know if they've been it's self-diagnosis, yes, but they have to be confirmed that it is actually a UTI that they're treating.
So that they have had a history.
Yeah, they have to have a history because they got to be able to know that, okay, yeah, I've had this before, no problem. Okay. But if it's the first one, they have to be investigated properly.
Makes sense. If there is just a little bit of blood in the urine, could we still prescribe antibiotics, or is blood a red flag?
Oh, a little bit of blood is normal, but it says excessive blood. You do have to realize, like, even I think it's from when somebody has a hemorrhoid, and I think like a little teaspoon of blood from a hemorrhoid, it's not a lot, but it looks like a lot in the toilet. So I would kind of think that same idea. Even so, if it's significant blood, yeah, refer. But it's normal to have a little bit of blood.
Okay.
And that's why it's good to have, this is not the first UTI. So then they will be investigating, okay, when I get a UTI, I might have a little bit of blood. But somebody asked if it's in all provinces. All the, we have Alberta, BC, Manitoba, Ontario, but the third parties, those are across Canada.
Okay. And I just wanted to also share in our follow-up email, we're going to have information on our Spilling Genie. So everything Shelley covered, like you'll have access to the contact information. There's going to be links there for you. And there's also going to be information on some of the UTIVA products that are relevant to the disease states that we talked about today. Right. So you don't need to like screenshot anything. It's all going to be there for you. And
like I said, just reach out to me on LinkedIn too.
Exactly. Okay, so does cranberry, maybe, okay, well, we can answer this now. Does cranberry, do cranberry capsules have any evidence for UTI?
Well, I was looking at the Canadian Association for OB-GYNs and the one in the States. So they said there's nothing wrong recommending it. And they had that as a 1A, which is a reasonable recommendation. Yeah, I know. I think I sent you the article of the study. I don't. I did send you the study, so yeah, I can't remember it off the time. But yeah, they did. And no, we shouldn't even assess males. We're not allowed to assess males.
And I'll just go back to the cranberry. I'm going to cover the proanthocyanidins after the Q&A just real quick. Okay. But I will say there's a good chunk of evidence for 36 milligrams packs, not just cranberry juice.
Right, because it's, half of it's sugar, half of it's.
So it doesn't have the
concentration
of what you actually need, but it is recommended. 36 milligrams are recommended by the Canadian Urology Association, the American Urology Association, the SOGC. So it's there. Yeah.
Yes, that was I was trying to remember what CUA stood for, but yes, that's but also the OB-GYN Association.
Exactly. And the family effective guidelines for family doctors. Okay, so is controlled, if they have controlled diabetes, should they still be referred?
I think it's more of their uncontrolled diabetes, I believe. Because then it's the sugars are probably the issue that might be setting off these yeast infections and UTIs. But I don't think it's an absolute. I'd have to double check, but
Okay.
I don't think it's an absolute.
Okay. There are some questions on D-mannose, and there was something about there's a combined product on the market. I'll cover those afterwards for you guys. That's tons of information. So the next question here is scenario example. If a female calls on Saturday afternoon and the pharmacy is closing, but the GP is closed until Monday. Okay, so just hang on here. The patient
Everybody's closed. Okay.
Yeah.
Okay.
The patient already took a week of antibiotics for UTI, but little relief. Would you prescribe another antibiotic or ask the patient to schedule the appointment with the GP on Monday?
Oh, I know we always feel bad, but like technically, if they've had it within that time, which is a week, it's not even past like four to 8 weeks. Is it 4 weeks for the UTI and 8 weeks for the yeast? So technically, they're within. They yeah. I would probably have to refer them because maybe what you're prescribing is what they were prescribed is not the sensitivity, would be my guess. And that, okay, you like sometimes, okay, we'll just extend it. It's probably not going to work. So unfortunately, I personally would not, because I just finished a course. It didn't work. Therefore, is it a UTI? Like, is it what they thought? Do they have any susceptibility, any cultures to know what it is? So, but that's hard. I know we want to help. We want to help.
So somebody else mentioned here, it could possibly be resistance as well.
Yeah, so yeah, but you're gonna just give them the same thing. So I think they would need a proper culture. So that would be nice if we could order labs and figure out what it was.
Sally, would you use UTI test strips in your farm? Like, do you use them in the pharmacy at all?
Yes, I do. And it's funny because I just she came with this was the example. She came with a fosfomycin prescription with 2 refills because the doc's like, oh, you get them all the time. And I told her, I was like, you know what? I wouldn't be running to always just, I feel uncomfortable. Let me just take it. So I told her, I'm like, I would suggest that you take use the test strips to confirm whether or not you have it before you take the medication. And she's like, you know what? That's a great idea. She goes, because I hate taking antibiotics all the time. So if I can avoid at least maybe 1 course of antibiotics, I'd be happy.
Let's see here. Macrobid, why 7 versus 5 days?
Why 5 versus 7?
Why 7 days versus 5 days?
Oh, that was a typo. Sorry. I did say it was a typo because it's supposed to be 5 days.
Okay,
it was a typo.
Easy answer there.
Yeah, they've said the longer duration doesn't increase efficacy, that the 5 days is good enough. And it just to reduce any side effects, any issues. The shortest duration is the best. Unless,
Yeah.
Right. But for us, the 5 days should be good.
I'm gonna, we have tons of questions in both areas. I'm gonna move it on. We're gonna move over to the yeast infections. So for yeast infection, did you say we give fluconazole with cream to relieve itch, or did I miss what you said?
No, it was fluconazole 150 PO and then the 1% clotrimazole for itch.
Okay. What about vaginal antifungal pills? Are they more effective than the oral fluconazole?
What did I? Oh my goodness, I did read that, but I was like, oh, I gotta remember that. It's slipping my mind. But even when you take the tablet, you still it still might take up to 3 days to work. Right? So if you're using and I think maybe the ladies like the topical better because you get that instant itch relief. which is the most significant, I would say, of the symptoms that you're suffering from. But yeah, so the tablet you take, because if you need, some docs will re-prescribe it in 72 hours, so 3 days after, to take it again. So
Okay.
he's still getting you 3 days, which is 3 days, I think.
That
But
makes
it's
sense.
just much more convenient.
Okay.
No fluconazole for pregnancy. Yeah.
Yeah, no, so there's a couple of questions, so just say it again. No
Mhm.
fluconazole for pregnancy.
Yeah, especially in the first trimester. I believe they said especially in the first trimester is what I read. And then I guess later on, if it's, risk outweighs the benefits. But, since there's the topicals work, I, as as a mother of 3, I wouldn't be running to take any if I was pregnant, to take any medication where there's not a safer alternative.
I was just going to quickly answer a question here, because we talked about UTI test strips. So somebody's asking, are they available in Canada? What are possible suppliers? They are available in Canada. UTIVA, we have great test strips. There's information in the follow-up email if you want more. But yeah, UTIVA for the test strips. Okay, let's see what else. Okay, we used to recommend Cysto Plus for burning symptoms if we had to refer the patient due to some red flags. That way they could at least get some relief until they see their MD. But Cysto Plus has been discontinued. What OTC do you recommend in these cases?
For the pain, it would just be
For the symptom relief.
Yeah, just symptom relief. Because she's talking about, did I hear you the pyridium, or what did you say?
I think Cysto Plus is pyridium. Yeah, I don't recall.
Because it's over you can still buy that in the States, but
yeah,
not here. Not
yeah.
here.
Do you see that a lot in your practice though? Oh no, it's not the same.
No.
Cysto Plus is sodium citrate. No.
Yeah, no, not really. Most people for the pain, I think most is just Tylenol or
Okay. How about boric acid ovules for, I guess, the suppository for, what is it? For
BB.
For BV, yes.
BB and
oh, sorry, for yeast infection. Yeah.
Well, they said there was some evidence for the non-albican yeast infection, and for those who don't have who can't take the azole. And I did have a BV patient in this past week, actually, and hers was interesting. They had tried metronidazole. I don't know what they had tried, but the doc wanted her to take metronidazole capsules vaginally. So I'm like, those aren't going to dissolve very well. So we switched them to the tablets, but she had tried the boric acid and didn't have a good response. She said it was like, but I have this is the OB-GYN building, who swears by the boric acid that works wonders. So, everybody's a little bit different.
Everyone's a little different. Yeah.
But like I said, it's the OB-GYN was saying how it was great because the patient was allergic to azole. So it was at least an alternative. But then it was on maintenance. So did the treatment, the 14-day treatment, and then do the monthly. I think it was for like 6 months with the 5 times for 5 days a month.
Okay. All right. I think we have time for two questions. So give me a moment here. I'm just gonna pick something. Okay. How many days do you prefer for Canestin? I usually say 3 if there's improvement, but still some symptoms continue. But if they still have some symptoms to continue to 6 days.
Yeah, I usually 3. If they're going to use a vaginal, I usually suggest 3 days.
Okay. Oh, this is a good question, actually. On the 5th day of antibiotic treatment for UTI, if the patient says her improvement is 60%, then can the pharmacist extend the treatment for 2 more days? So
And
I
this is
think the case here is that they're already on treatment from their
Well, yeah,
doctor.
well, I guess 7 days is a reasonable treatment, right? It's not, you're not going past the 7 days. We're doing 5 to 7 days. So, you could have technically prescribed 7 days initially. But
There were a
but do you know
couple.
that like it
Sorry.
still continues to work after you take the medication just doesn't stop working on the 5th day. It's still in your system. So yeah, I don't see, I wouldn't see why it would hurt.
Okay.
Probably
Um,
really helps the UTI thing. Yeah.
okay, there's a few questions on Utiva. I'm gonna cover those in like
Okay.
the next 5 to 6 minutes if you guys want to hang on, just stay patient. But I appreciate all the questions. And okay, so for the first yeast infection, for the first UTI, you said that they need to see their doctor first. Is it the same for the first yeast infection? Do they need to be assessed by a physician first?
Yeah.
Okay.
Yeah.
And there were a couple questions on the parameters with treating patients who are underage. With their parents come in, are you able to prescribe something for them for UTI or yeast infection if they're under 18?
Well, definitely if they're 16 or older, because they're
All right.
autonomous. Like a parent can't even know what's going on with the family doc and a 16-year-old. So, the 16 for sure. The 12 to 16, the 12 to 15. Yeah, I don't see. Yeah, but have they been diagnosed before?
See, that's the caveat, right?
Right.
Okay.
Have they been
I'm sure that's
diagnosed
helpful.
before?
Yeah.
And if they've been diagnosed and they've had treatment possibly at your pharmacy, you have a history, you know.
Okay. Shelley, there's just maybe if you can address these. There's some questions in the chat or comments that are kind of relevant to each other regarding symptom relief, pain relief, Peridium, using Peridium basically. Did you want to comment on those? You're saying
Because we
doctors
don't
are
have
still prescribing Peridium is really helpful for UTI pain.
I've used it myself before. I found it was helpful. So,
Yeah. So is
but
that
yeah,
something
yeah.
you would
But I don't think it's available. I think they're saying it's unavailable
It's
as well.
unavailable. I see. But they're saying it can be compounded.
Oh, well, of course. Well, if it can be compounded.
Yeah.
That would make sense.
Somebody else
Then
said
it's a fair option. I was just thinking what we can give over the counter. But yeah, if it can be compounded, of course.
Okay.
But like I said, it's still available in the States.
Yeah.
And Cysto is good as well. Thank you.
Yeah, somebody originally had said Cysto has been discontinued, but then a few people said no, it's still available. So I don't know about that. But yeah. Okay. I mean, there's so many other questions, but I think we need to eventually stop somewhere. But but what I will say is if you have a burning question that you were really hoping would have been answered during the Q&A today, send me an email on the follow-up and we'll do our best to answer that. Okay, just so you feel like you didn't miss out or anything like that. I want to thank Shelley so much for your time and your expertise, sharing your information, and yeah, just being
so
here with
much,
us.
everybody. Thank you for having me.
Of course, it was great, and I mean, I learned a lot. I'm sure everybody else learned a lot as well. And I just want everybody to know that the replay will be available next week if so you can look back and also look at the chat and see what all your peers were sharing. And yeah, I think that's it. So thank you so much, Shelley. I'm going to move on to the raffle and then the Utiva presentation, but I'll say our goodbyes here.
Thank you, everyone. I appreciate it so much.